Great. Thank you very much for that kind invitation, and it's a pleasure to be here. I really enjoyed Dr. Tapia's presentation and really looking forward to Dr. Beraldi's talk on BPD. And I'd like to start with a little bit of an editorial, and that is, this is a respiratory course. So for pediatric pulmonologists or respirologists, it's so wonderful to see more of the group in that subspecialty become more engaged in the neonatal ICU, as well as long-term follow-up of our babies. And as we'll hear, in terms of long-term outcomes in adult life. And so it's great to have a perspective from the neonatologists, the pulmonologists, the cardiologists, and others in terms of how to approach the premature infant to improve outcomes. And I do have to disclose I have some relationships with industry. There are a few grants I have for laboratory research, 2 groups that I work for on their data safety and monitoring boards for ongoing clinical trials, as well as some educational activities that's funded by a pharmaceutical. And as we think about pulmonary hypertension of the term newborn, we've learned many things over the years. We've learned many different mechanisms that allow the successful transition of the pulmonary circulation from a high resistance bed in utero to a low resistance, high flow circulation at birth. And of course, this transition is absolutely vital for the lung to take on its role as a source of oxygen for the baby once we lose the placenta. But we've learned over the past few decades that in the term newborns, this failure of transition really represents the result of antenatal factors, worsened by perinatal factors, leading to changes in the blood vessels in the lung that lead to sustained vasoconstriction or even vascular structural differences. And it's become a challenge with how to manage their course. And over time, as illustrated on this slide, here is a baby on ECMO therapy who's also on a high frequency oscillatory ventilator to help recruit the lung. And there's a tank of nitric oxide gas in the background, all being used to hopefully sustain this baby and improve outcomes. Well, this is the term newborn. And as you know, today's talk will be on the preterm infant. And for a long time, there was a misconception that the premature infant did not have enough smooth muscle around the blood vessels in the lung, meaning that vasoconstriction was unlikely to be a big factor shortly after birth. And what we've learned through extensive laboratory studies and clinical studies and beyond is that indeed, as highlighted by this other picture of a sick preterm baby on a ventilator who looks hydropic, who has severe pulmonary hypertension, these babies can also have PPHN or acute pulmonary hypertension. Not all babies who are apoxemic, who are prematurely born, have significant pulmonary hypertension, but the subgroup that do have the same physiologic features as do the term newborns. So there are many controversies in how to manage acute pulmonary hypertension of the preterm infant. And I would love to discuss this further, perhaps in the questions later. But it also tells us about other phenotypes of the abnormalities of the lung circulation, in particular pulmonary hypertension in the setting of BPD or bronchopulmonary dysplasia. And this is an infant who's several months of age, has a tracheostomy, is on a mechanical ventilator, who also had severe pulmonary hypertension that worsened over time and improved with mechanical ventilation and the use of modern pulmonary hypertensive targeted drug therapies. And I'll talk about that in just a moment here. And so what my overall objectives for today really is to first describe our current understanding of pulmonary vascular disease in premature infants who are at risk not only for pulmonary hypertension, but perhaps for severe BPD as well. To then talk about very briefly how preservation of lung vascular growth, what's known as angiogenesis during the perinatal period, may decrease not only the risk for late pulmonary hypertension, but also may improve how the distal lung grows. In other words, it may attenuate the severity of underlying bronchopulmonary dysplasia itself. And then finally, briefly talk about the early identification of at-risk infants and some issues around their management to improve late outcomes. And this is a slide from a conference showing Bill Northway in the middle here. And this conference celebrated the 50-year anniversary of Bill Northway's observations of BPD. Bill is a radiologist, and he came back from a sabbatical in France and put together the clinical, radiologic, and pathologic features which carefully phenotyped this disease they labeled as BPD. Now that was 50 years ago, and many, many things have changed. Right behind him is Alan Jobe, and I like to show Alan because Alan has really played a major role in helping us understand critical therapies, such as antenatal corticosteroids, or the use of surfactants. And certainly the two of them really represent the old and the new BPD. And of course, if there are other speakers here, I'd love to have Eduardo Bancalari. I would love to have Dr. Baraldi here as well, as we learn more about what this new BPD is all about and what we should still be concerned about. And this is a slide from Dr. Baraldi, a very famous slide, stimulating much work and thinking in the field. And it's nicely characterized the transition of our understanding of BPD from the old to the new. Now, the old, back in Bill Northway's days, as you see on this slide here, is characterized by fairly borderline immature babies, 34 weekers, maybe 32 weekers. They had terrible survival. But Bill put it together that postnatal exposures, such as hyperoxia, ventilator-induced lung injury, infections, and many other things postnatal played a huge role in their survival or mortality and identified many things for us to target to improve outcomes. With the improvements around the perinatal period, it's been more greatly recognized what Dr. Baraldi highlighted in this slide. And this has become more to the forefront. And that is even before you have those postnatal exposures, severe premature birth is highlighted here, meaning babies who are born during the saccular stage of development before the alveolar ducts and sacs are formed. They're born at 23, 24, 26 weeks. They really represent a different kind of baby, extreme prematurity. But then what really drives outcomes such as chronic lung disease and pulmonary hypertension has been influenced clearly by antenatal stress. And as highlighted here, chorioamnionitis, features of intrauterine growth restriction, maternal hypertensive disorders of pregnancy, such as preeclampsia. Many of these things on top of prematurity set the stage for BPD and late respiratory disease during childhood and beyond, even independent of many of the things we do after birth. And it's this interaction of antenatal exposures, severe prematurity, and postnatal injury that sets the stage and is the driver for the severity of underlying pulmonary and cardiovascular disease. So this slide, we tend to stop around 36 weeks, but as you know, for us as in pulmonary medicine and other aspects, it's only beginning, right? We see these kids who come back and forth from the hospitals, from the emergency room with respiratory infections. We see them as they become adolescents with abnormal lung function tests, and we're about to hear more about that. But in addition, they have underlying pulmonary vascular disease, or they may have overt pulmonary hypertension, and that's what I'd like to target. So as we evolve from old BPD, characterized by severe lung injury, to so-called new BPD, the post-surfactant era, where it's more of an arrest of lung growth and development, we've gone from tissue at autopsy that shows striking fibrotic changes, along with fewer alveoli and fewer vessels, and even pulmonary hypertensive vascular changes. Now, when babies die with BPD, we see perhaps less striking fibrosis than we once saw. But as the arrow shows in the lower right here, we still see evidence of pulmonary hypertensive remodeling, blood vessels that have extensively overgrown and are reducing the lumen of the vessel, minimizing the ability to get blood flow through the lung causing right ventricular dysfunction, and either as a marker or a cause of poor outcomes in this population. So even in Bill Northway's days in 1967, all of the babies who died, and many of them did, he noted that cor pulmonale was present. The pathogenesis is puzzling, but most of them, but not all of them, had striking cardiomegaly, especially in the right ventricle. And he was concerned about the issue that pulmonary hypertension was always present in fatal BPD. Now, here we are in 2007, work from Boston Children's Hospital, and we're still seeing that pulmonary hypertension is dramatically associated with poor survival in BPD. And this appears to be in a dose-response fashion. Mild pulmonary hypertension, less of an impact than severe, but you could really see that this is important in terms of outcomes, especially during the first few months after the diagnosis is made. And I think that's something we'll get back to in just a minute. So what's the relationship of pulmonary hypertension and the severity of BPD? Well, there are 3 prospective studies. One is from Colorado, and we found, as did the study from Seoul, Korea and Alabama, that roughly 14 to 25% of prematurely born babies will have abnormal echoes, suggesting pulmonary hypertension at 36 weeks corrected age, with the vast majority of them being in this label of severe BPD, meaning more than 30% oxygen with some level of additional respiratory support, perhaps up to 50 or 60% of that group, especially in the kids who require ongoing CPAP or mechanical ventilation at that time. Now, recently from our network, we did a registry looking at as many cases of pulmonary hypertension as we can across many sites. And I show this because it shows the 5 classic groups for pulmonary hypertension. Group 1 on the right there has our congenital heart disease and many other forms, and that's what we used to focus on predominantly. But look at what's here in group 3, that is chronic lung disease. It's almost as big a signal as our congenital heart and other forms of pulmonary hypertension. And most of those are BPD infants. And these are babies who are consented for a study, meaning this is the tip of the iceberg of how common pulmonary hypertension is in terms of our patients with chronic lung disease, but especially with bronchopulmonary dysplasia. Well, what's the underlying physiology? Well, years and years of work in the laboratory and clinically of many different people have shown that vascular tone, that is constriction or dilation and reactivity, play major roles. And we've learned a lot about nitric oxide. Nitric oxide is important at birth. The absence of nitric oxide leads to PPHN and sustained pulmonary hypertension. Likewise with prostacyclin, and excessive endothelin or ET1 causes vasoconstriction. And there are other features that change tone and reactivity. And currently, most of our pulmonary hypertensive therapies are exclusively directed towards these kinds of mechanisms. But they're not the only cause of high pulmonary vascular resistance or pulmonary hypertension. Structural changes or remodeling of the intima, the media, the adventitia lead to a more narrowed, stiffer vessel, making vasodilation problematic. And at least in the newborn especially, this idea of vascular growth is so critical, and that's what I'd like to highlight. What's unique in the preterm who's at risk for pulmonary hypertension or has pulmonary hypertension is this impaired vasculogenesis, that is de novo formation of blood vessels, but mostly angiogenesis, which is how the vessels grow their surface area and have to grow in coordination with the distal airspace. So growth, remodeling, tone, reactivity all contribute to high pulmonary vascular resistance, especially in the premature lung. The other feature I'm going to mention, this other idea, beyond growth and resistance, the vessels themselves are a rich source of signals that tell the lung, air spaces even, how they should grow. And we call it angiocrine signaling. So products derived from the endothelium can cross over to the epithelium to develop septae and alveoli. And so it's that crosstalk that's important for not only vascular surface area, but also alveolarization. And they're also promise as we think about how to preserve growth or regenerate lung. Perhaps they're a source of lung regeneration through these endothelial mechanisms. And that's more of a science question for now, but very exciting to consider. What do we know about pulmonary hypertension's origins? This wonderful review speaks, first of all, the idea that, of course, extreme prematurity and low gestational ages are important. But it also shows this. Being small for gestational age or having IUGR is a huge risk factor. Having an antenatal stress induced by oligohydramnios, which really limits how the lung can grow in utero, also plays a major role. And so these things speak to the idea of intrauterine stress causing disease. Karen Meston's group in Chicago and many others now have duplicated her findings, and she had the original observation that abnormal placental histopathology suggesting the underperfusion of the blood vessels in the placenta are associated with intrauterine growth restriction, and that when she tracked these babies over time, not only did they have high risk for BPD, but high risk for BPD and pulmonary hypertension is shown here. In other words, when she looked at echoes at follow-up in her babies, there was an enriched group of the pulmonary hypertension population who had growth restriction, suggesting that perhaps antenatal mechanisms contribute to this risk. Now, just very briefly in the laboratory, an animal model of intrauterine growth restriction also shows these kinds of findings, and it's highlighted here. Work from Colorado has shown that if you have sheep, fetal sheep, and you make them growth restricted, in other words, you cause placental dysfunction by exposure to heat during late gestation. If you then take those lungs before birth out, they're abnormally grown as highlighted here. You could see the very few alveoli have formed. You could see septation is markedly limited and dilated air spaces are present. And the number of blood vessels are markedly reduced. And that's reflected here, reduced radial alveolar counts, meaning fewer alveoli, and a more marked reduction in vessels per high-powered field. And then again, more laboratory stuff. If you take these cells out from the lung, remember, they're not hypoxic. They're not having other kinds of stressors, but just IUGR itself from the heat was enough to induce cells that don't grow or form blood vessels, not only in vitro, but when you put them in vitro and study them in different conditions and try to stimulate growth is highlighted here. So the idea overall then, with much work in the laboratory connected with these clinical observations is highlighted here, that maternal stress, such as inflammation from chorioamnionitis or hypertension, like in preeclampsia, affect the placenta, which then alter fetal programming, setting the stage above and beyond just premature birth alone for cardiopulmonary problems later. And so this has been shown in many different cord blood studies that perhaps the mechanisms are related to disruption of angiogenic signaling. This is marked if you take cord blood of these babies at birth, before they're on a ventilator, before any other changes are going on, they have a reduction in progenitor cells that are important for angiogenesis. They tend to have lower angiogenic growth factors that circulate, such as the VEGF or vascular endothelial growth factor, which I'll mention again soon, and increased anti-angiogenic factors. And many studies have borne this out. A fairly consistent story and very interesting. And these very things that happen before birth then, we think, sets the stage for poor growth of the lung in utero, the vascular injury that mediates this, the risk not only for acute PPHN in the first days of life, but for more long-standing risks for subsequent development of cardiopulmonary disease. Now, we saw this a little bit more laboratory first, is that we had animals, we had these old models of sheep where we closed their ductus arteriosus in utero to cause PPHN. We studied PPHN in different ways. What was always apparent is that these lungs, as shown here, are clearly smaller than the control neonatal lungs, showing impaired fetal lung growth. Oh, that's interesting. And certainly the lung weight to body weight ratio is reduced. Vessel density is reduced. And indeed, when you looked histologically, the air spaces were reduced as well. And that was really interesting because they're not hypoxic, they're not growth restricted, but this hypertensive stimulus in the blood vessel was significant enough to cause impaired lung growth, as highlighted here. And so when we gave a number of drugs to block angiogenesis, and you can see the simplification here, we gave drugs that block angiogenesis, we caused pulmonary hypertension, and this lasts through infancy and into adulthood. So our hypothesis that early disruption of angiogenesis during critical periods of lung growth impairs alveolarization. Strategies then that target the endothelial cell and improve pulmonary vascular function may decrease the risk for BPD. So the question then is, what does that mean clinically? And we did a cohort study of premature babies and enrolled them and looked at what happens in terms of their echocardiograms early on to see if that would produce some sort of signal that told us there's a link between early pulmonary vascular disease that was related not only to late pulmonary hypertension, but also to BPD. And indeed, when we did echocardiograms at day 7 of life, not because they had PPHN and hypoxemia that was concerning, but just as part of a research protocol, we found that echo abnormalities were associated with septal flattening at day 7, was associated with BPD severity as well as late pulmonary hypertension. It was also associated with late respiratory complications during the first 2 years of life, not necessarily from pulmonary hypertension in the right ventricle, but impaired vascular growth seemed to make these kids more susceptible for more ER visits, more asthma exacerbations, and other kinds of problems. And so this has been brought out further by others who've shown that early pulmonary hypertension is associated with higher mortality in preterm infants with BPD. And it shows some of the features we were concerned about as early vascular injury sets the stage then for the diagnosis of PH and may then contribute to worse pulmonary courses, higher rates of mechanical ventilation at 36 weeks, and indeed worse outcomes and as well as more evidence of pulmonary hypertension. So what can we do now? Well, certainly there are some early things that suggest that simple interventions, like avoiding hypoxemia early, may help reduce the risk for late pulmonary hypertension. And this is from an NICU where they targeted either higher or lower saturations, and not extremes, right? Like the low at 88 to 92% isn't extremely low, but they avoided hyperoxia or normoxia, normal targets that we would use. That's more what they call the high range. But if you look at the high range, you could see that there was a lower risk for developing late PH than those who are still exposed to intermittent hypoxia, still in that 88 to 92% for sustained periods of time, suggesting that if we are more attuned to maintaining better saturations early, perhaps we could reduce the risk for pulmonary hypertension. Secondly, ASDs or atrial septal defects are also associated with higher risk. This is very problematic because, as you know, the ASD itself can be a pop-off for a baby with bad pulmonary hypertension. And I'm not saying everyone should have an ASD closed, but if you have a little bit of extra flow into the lung circulation that's smaller, your risk for pulmonary hypertension is likely greater. And so finally, when we think about the heart-lung interactions and BPD-associated pulmonary hypertension, this guides how I think of our overall strategies to manage them. Is first, we manage the lung disease in terms of avoiding hyperinflation on the ventilator or atelectasis. We avoid hypoxemia because they're very sensitive to hypoxia. Small changes in PO2 make large increases in pulmonary artery pressure in many of these kids. And so finally, hypercarbia can also either be a marker or something to target for the need for more aggressive respiratory support. Heart disease, we certainly think about right ventricular dysfunction, but even having problems with the left ventricle is becoming more prominently recognized now. Left ventricular diastolic dysfunction can cause pulmonary venous hypertension, worsening pulmonary hypertension. That's something we see manifested by pulmonary hypertension that sometimes has a little more edema from the injury. or to assess how much shunt from an atrial septal defect, a PDA, or a VSD contributes here. And then finally, we then target pulmonary vascular disease, and that's where we use our newer agents such as nitric oxide, prostacyclin, or endothelin blockers. And I think I'm really right at the limit right here with my time. And I'd be happy to talk more about therapies and different challenges, but I think these three spheres of managing the lung disease first, making sure they don't have significant malacia, checking bronchial hyperreactivity, treating lung inflammation and mucus clearance. All these things we learn as pulmonologists are vital for treating their PH, their pulmonary hypertension. Heart disease plays a role. Make sure we don't give dilators to those with a bad left heart. And then finally, the different drugs that are available, the inhaled nitric oxide, the prostanoids, the endothelin blockers all come into play. So I want to thank you for your attention, and I appreciate having this time to share some of my thoughts about this. Take care.